Good afternoon, everyone, and thanks for joining us. I am Rachel Werner, the Executive Director of Penn's Leonard Davis Institute of Health Economics. LDI is Penn's hub for research on healthcare delivery, health policy, and population health. Our more than 500 research fellows are national experts and thought leaders in this space. And for those of you who have joined us before, you know that we often host events bringing together experts to talk about some of the hottest areas in health policy. These seminars are typically planned well in advance, giving us plenty of time to prepare. But since January, the pace of policy change under the Trump administration has been fast and furious, and at times it's been hard to make sense of and understand what these changes mean. To help with that, we got together with our colleagues at the nonprofit news organization Tradeoffs to organize this new series of seminars called Decoding the Moment. Together, we are taking important news from the Trump administration and creating a space to try to understand what's happening and what it means for the future. Our first conversation today will unpack the latest from the Trump administration on vaccine approval policy. To structure this discussion, we asked for input from you, our audience, about what questions the recent announcements have raised for you. More than 700 people registered to participate in this seminar, and 125 of you sent questions in. So thank you for all of those questions. We have carefully reviewed them, and we've incorporated them into the planned conversation today. We have several more seminars like this one planned after, and you'll hear more about that at the end of the show. Additionally, you'll be able to find a recording of this seminar on LDI's website later next week. With that, I'm going to turn it over to my colleague, Dan Gorenstein, who is the founder and executive editor of Tradeoffs.
Thanks so much, Rachel. Really appreciate it. We're so excited for this collaboration with LDI at such an important, critical moment in health policy. As Rachel said, I'm Dan Gorenstein, the founder and executive editor of Tradeoffs. If you are new to Tradeoffs, we're a nonprofit newsroom that covers healthcare's toughest choices. We produce a weekly podcast called Tradeoffs. You can get that wherever you listen to your podcasts. We've been closely covering many of the changes to health policy coming out of the Trump administration these past few months, including around vaccines. Earlier this month, as many of you know, the Department of Health and Human Services said in a move to increase transparency, all new vaccines will undergo safety testing in placebo-controlled trials prior to licensure. The agency added that that is a radical departure from past practices. HHS has provided very few details about its new policy, including how the change will be implemented, even what the definition of a new vaccine is. Public health experts are worried this shift could make vaccines more expensive, harder to get, and ultimately undermine the public's trust in vaccinations. That includes any COVID-19 vaccine updates. The head of HHS, as you all know, is Robert F. Kennedy Jr., a vaccine skeptic. In this new role, RFK Jr. has arguably further exacerbated concerns over vaccines, though others would argue he's attempting to address long-standing concerns. Our goal with today's conversation is to help you decode this policy announcement from the Trump administration. We're going to break it down with the help of data and evidence, what exactly the administration says it wants to do and what it could mean for vaccine availability, public confidence, and disease spread. As Rachel mentioned, 125 of you submitted questions when you registered. That is so awesome and amazing. We really appreciate it. And it clearly speaks to the hunger out there for good, solid, reliable information. We've included a handful of questions that you all submitted. We'll get to some of them over the next 40 minutes. We also, and this is important, encourage you to communicate with the other attendees in the chat. We know that we have a lot of expertise on this call, and we hope that part of what we can do through these events is create a place where you all can connect and learn from each other as well as the speakers. To help us dig into this new policy, I am joined by Alison Buttenheim and Paul Offit, and I'm going to ask them to briefly introduce themselves and their expertise on vaccines. Alison, let's start with you. Nice to see you. Thank you both.
Nice to see you, Dan. I'm Alison Buttenheim. I'm a professor of nursing and health policy at the University of Pennsylvania. I'm a behavioral scientist, and I study vaccination behavior, vaccine confidence, and the policies that shape confidence and demand.
Your turn, Paul.
Yes, my name is Paul Offit. I'm the director of the Vaccine Education Center at Children's Hospital of Philadelphia and a professor of pediatrics at Penn's Medical School, and was fortunate enough to be part of a team at Children's Hospital of Philadelphia that created the bovine human reassortant rotavirus vaccine, Rototec.
Great. Thank you both for being here. We really appreciate it very, very much. Paul, I'd like to start with you. I'd like to set the table little bit for everybody on the call. Can you describe how the U.S. government currently safety tests vaccines before they're approved for public use? And this is a question that we got from Lucinda Caruso and a few other folks.
So typically, when a company makes a vaccine, they do a series of phased increases in terms of the number of people who are tested. So sort of the phase 1 trial, they're trying to figure out what's the right buffering agent, stabilizing agent, what the right dose, the right number of doses, whether all strains need to be there. Then they think they've got it. They think this is going to be the vaccine. So then they go to phase 2, which involves a couple hundred people, which will tell them there whether or not there's a common serious adverse event. Then it goes to phase 3, which is tens of thousands of people that get either vaccine or placebo. And that will tell them whether or not there's a relatively uncommon serious problem with the vaccine, serious safety problem. Then comes the bigger trial. Once the vaccine is out there, there's so-called post-marketing surveillance systems like the Vaccine Safety Data Link, which then will tell you whether there's a rare serious adverse event. And COVID's a perfect example. I mean, myocarditis was a rare adverse event associated with the mRNA vaccines. It occurred in roughly totally about 1 in 50,000 people. It was higher in certain subgroups. That was picked up within weeks. And then with the Johnson & Johnson vaccine, which was the so-called adenovirus vector vaccine, that very quickly was found to be a rare cause of clotting, including serious clotting, that occurred in 1 in 250,000 people, so extremely rare, and yet picked up quickly.
Great. Thank you. And so let's move to what the administration is proposing. As I mentioned, there's very little that we know. And there's some super basic questions out there that need to be answered to better understand this, including what does constitute a new vaccine, and what kinds of adverse events and at what frequency would deem a vaccine unsafe versus safe. Paul, based on what you've been able to glean, what is your understanding of the proposal? How does the Trump administration want to change vaccine testing? And if you can do this, giving us an example to help illustrate it might be useful for folks. If you don't have an example, that's okay.
So the administration has made it sound like we're entering a new and golden age of vaccine testing, where now we're going to do placebo-controlled trials for new products, which we've been doing pretty much for the last 80 years. So I'm not sure what they're talking about. If you look at a truly new vaccine, like the human papillomavirus vaccine, for which there was not an existing vaccine, that was a large placebo-controlled trial. The rotavirus vaccine, when it came out and was ultimately licensed in 2006, there was not an existing rotavirus vaccine at the time, so that was a placebo-controlled trial. The same thing's true for a number of other vaccines. If you look at
so real quick, and just to make sure everybody's staying with us. So a placebo-controlled trial, that means that half the people were getting this entirely new virus and half the people were getting like a saline shot or whatever.
Or the diluent, that's right. Or saline or the diluent, meaning everything that was in the vaccine except for the actual vaccine component itself. That's right.
Okay, go on.
And so for example, when the pneumococcal vaccine came out, to prevent the bacteria pneumococcus, which can cause meningitis and sepsis and pneumonia, when then another vaccine came out that had more serotypes in it, had 13 serotypes instead of 7 serotypes, that wasn't tested against placebo because that wouldn't have been ethical, because you knew you had a vaccine that worked against pneumococcus, even though it contained fewer serotypes. So you would test it against that vaccine. That's what I mean by new vaccine, meaning not an existing vaccine. If you look back at the measles vaccine, for example, the last best measles vaccine came in 1968. That wasn't tested against placebo because there were existing measles vaccines at the time. So it was tested, so comparing it to those vaccines, not to a placebo.
And so just to come back here, so the Trump administration is they're talking about this golden age as you talk about, but like I know you've said in the past that the goal of this policy, as far as you can tell, is to make vaccines less available and less affordable. What makes you say, like, what do you really see as the agenda here?
I think it's cynical in many ways. I think the goal is to scare people at some levels, to say, you know, we're not going to do something we've never done before. We're going to really test these vaccines to see whether or not they're safe or effective, because we don't really know that. Now we're going to know that. And I think it's very cynical. I think it's a way to just further sort of decrease trust in vaccines and the vaccine infrastructure. And I think it's just, you're just going to see that continue to go along. You know, there's statements now about how they don't want to recommend a COVID vaccine for children as a yearly dose, that they don't want to give the COVID vaccine to pregnant women, say for every pregnancy or whatever. And I just think it's going to be a gradual erosion in vaccines. And so, for example, if you let's say that they do follow through with their threat that they're not going to give a COVID vaccine yearly for children, first of all, does that include all children, including children at high risk? And what will that mean then for people who want to give the vaccine? Will the Vaccine for Children's program not cover it? Will insurance companies not cover it? Will this make it more expensive and less available? Because I think that's the goal. I think Robert F. Kennedy Jr., our Secretary of Health and Human Services, has been an anti-vaccine activist and science denialist for 20 years, and he's still that guy.
Thanks, Paul. Alison, turning to you, I know from you and I talking in the past, you, like Paul, see this as I think I'm more or less quoting you here, a deliberate strategy to undermine confidence in vaccines cloaked in the guise of more rigorous safety testing. Why do you think that? What are you piecing together that makes you say such a strong statement?
Yeah, I mean, I think you can so clearly pin each of RFK Jr.'s strategies here to the misinformation playbook. I mean, it literally is straight out of the playbook. It's clickbaity stuff. It's setting up impossible expectations about what vaccine safety testing and vaccine effectiveness looks like. They're logical fallacies. Everything Paul just talked through about the golden age is a straw man argument. And it's leading you away from the reality of this is what we already do. And, you know, I share Paul's take of this being quite cynical and quite deliberate in undermining confidence so that, you know, regular high coverage vaccination for these vaccine preventable diseases doesn't happen. I mean, they seem to want less vaccination and less protection against these dangerous diseases, which just seems horrendous.
And just before we talk about the stakes, I just want to talk a little bit more about the mechanics. I would like, this can be a question to either of you. I would just like to walk through if this policy, this placebo policy proposal does go through, what would actually change? Paul, you described before what we do now. What would be different under this new policy? And
so it's hard to know exactly what they mean. So for example, all new vaccines are tested against placebo. So if there was a vaccine against parainfluenza virus, there's not a current parainfluenza virus vaccine, that would be tested against placebo. But what the administration sort of alluded to, and again, we're just reading the tea leaves, they said they don't consider the fact that we update influenza vaccines to the current circulating strains a new vaccine, but they would consider the fact that we update COVID vaccines to consider the circulating strains as a new vaccine. They had mentioned that. Well, what does that mean? Or you can't do a placebo-controlled trial against, you know, with the COVID vaccine because SARS-CoV-2, the virus that causes COVID, still circulates. That's not an ethical study. What are they looking for? Are they looking for a better safety profile because they don't feel they have a safety profile, even though this vaccine has been given to billions of people? Are they looking for efficacy data at a time when population immunity is high? And it would be kind of hard to do that kind of study. What do they mean? And I think that's what's so frustrating about all this is that, you know, when I talk to journalists about this, we all had the same conversation, was like, what do we think they mean? They should stand up in front of the American public and press and explain exactly what they mean and answer questions.
Let me talk, Dan, about a different mechanism through which this
Please.
might operate. So I don't know if everyone on the call knows this, but most vaccination law and regulation happens at the state level. This is definitely true for example, what vaccines kids have to get before school entry or daycare entry, and the exemptions that parents can get, for example, or employees can get if they're under a vaccine mandate. What I think a policy like this at the federal level does is open the door in state legislatures to propose all kinds of bills that might sort of loosen up our vaccine mandate system. So state legislatures are a very active area for vaccine policy. I think in the last 4 or 5 years, there have been something like 2,500 bills related to immunization and exemptions introduced in state legislatures, just 400 in the past legislative cycle. And you can imagine a state that where the state legislature isn't crazy about vaccinations, taking this federal law and saying, okay, you can only mandate a vaccine that's been placebo controlled trial tested. Or, there's states introducing bills now that you can't mandate an mRNA vaccine. And, lots more opportunities for parents to exempt from that. So I think that there's really a floodgate concern there at the state level when the federal policy is rolling back, approving and supporting mandates for these vaccines.
And so as RFK Jr. has said, he's pro-safety, he's pro-transparency, pro-accountability. That is sort of the umbrella that this is. And what's that all sounds pretty great. Like, who doesn't want more transparency, more accountability, more safety? Why, Alison, is that? What makes it clear to you that that is disingenuous?
Because it's so counter to the facts and the history that Paul laid out for us. If you wanted to make sure vaccines were more safe, this is not the policy that you would pursue. There's no consistency between the policy as stated and reality. That leads me to think there have to be ulterior motives here, which are, again, much more consistent with prior statements and actions that RFK Jr. has taken.
Right. And if we're talking about more transparency, it's hard to talk about transparency at a time when a policy is introduced and there are zero details. Okay, let's turn to potential stakes of this change. And I see lots of people are talking to each other in the chat. That's super awesome. I'm really glad for that. Joe, hope I'm getting your last name right. Joe Zikafus asked what the challenges and benefits of this approach would be. Alison, let's start with you. The administration says the benefit of doing this is to give people more confidence. Based on the evidence that we have, is it likely that this is going to increase people's confidence in vaccines?
I don't think it will. I'll bring kind of a wonky behavioral science answer to this.
Please. That's part of why you're on the call.
So people like to be really consistent with their prior actions, and they work hard to make sure their attitudes and beliefs are aligned with their identity. So if what you think is going to happen is that folks who are hesitant or skeptical about vaccines will suddenly change their mind because now RFK Jr. has sort of saved us with this new, more safe vaccine approval process, that's very unlikely. What's more likely to happen is people will see, oh, aha, there's been reason to mistrust these vaccines all along. Great, I'm doubling down on my skepticism and hesitancy around these vaccines because RFK Jr. has had to introduce this policy to undo all this, seemingly dangerous behavior. So they're much more likely to, I think, double down on prior beliefs and prior actions than suddenly change their mind.
And just real quick, because you understand the evidence, the literature, how persuasive, how reliable is the literature on this point, Alison?
Oh, pretty reliable. Yeah. Self-consistency, consistency with prior actions, the role of identity and social networks in driving intentions and behavior is very robust.
We run a news organization called Tradeoffs, so I feel like obligated to ask this question. Do either of you, and we'll go to you first, Paul, on this, any upside to this proposal? Is there anything to like here?
So it's what he says versus what he really means. What he really means is he doesn't trust the system. He doesn't trust the system because the scientific data that have been generated don't support his fixed, immutable beliefs, such as vaccines cause autism. I mean, there have been 24 studies at this point looking at whether the combination measles, mumps, rubella, or MMR vaccines cause autism. They've all found the same thing, no association. He doesn't believe that. He doesn't. And so when he talks about gaining trust, it's really just a smokescreen for what he really means, which is he's lost all trust, and he wants to kind of do the studies that will support his belief. And I worry that over the next year or so, he's going to do a study that he will be done poorly, that will sort of fit his fixed beliefs or shoehorn his fixed beliefs into data that will be just as bad as that paper he held up at that second confirmation hearing, that paper by Mawson and colleagues, which was a Medicaid paper out of Florida, which he said, see, vaccines cause autism, never published in a scientific journal, never published in a medical journal, never peer-reviewed, supported by an anti-vaccine group, didn't show that at all. It was horribly flawed and therefore uninterpretable. That was his, as he said, gold standard study. That's who you're getting as the Secretary of Health and Human Services.
But let me hold. Thank you for sharing that. But is there any upside to any part of this proposal, even if it's sort of more meta or more processy, the fact that we're having these conversations? Do you see anything to like here?
I don't know what the proposal is. I mean, he said that we don't do placebo-controlled trials. We do. He's now said that maybe the COVID vaccine is a new vaccine, even though all we've done is just use a different Omicron variant. Although I'm not even sure this year that's going to be a different Omicron variant. It still may be KP2 or JN1 as what forms the base of the vaccine. So I don't know what it means. How big of the study is? It a safety study? Is it an efficacy study? I don't understand this, except that it's just sort of roiling the pot to make people less confident about the way we've been doing things.
How about you, Alison? Any upside here? Anything to sort of say, well, at least?
Yeah. So two silver linings we might look for in a situation like this would be, don't let a good outbreak go to waste. So these policies and RFK Jr.'s policies in general around vaccine will lead to more disease. We will have more measles. We will probably have pertussis. God forbid some of the ones that have nearly disappeared come back. That can raise the stakes for people. It's really easy now not to worry so much about measles. Most pediatricians have never seen a case of measles. Most parents, the 95% of parents in the country, more than that, vaccinate their kids. When you see levels of these diseases coming back, suddenly people pay attention a little bit more and be like, oh, it is really important that we do this vaccination. Measles is really worse than anything I might worry about with the vaccine. So we've looked for that with evidence of prior measles outbreaks and other vaccine preventable disease outbreaks. The evidence isn't huge, but hopefully you can get some kind of spotlight or attentional effect. The other piece, and it's related, is that we do a better job framing for the public what a national asset our herd immunity against these diseases is. We don't tend to frame it that way, but we have invested heavily in it over decades. It is very valuable, and it is very, very expensive to for example, track a measles outbreak versus run an effective and safe vaccination program. And I think especially the folks who are looking at the bottom line and worried about costs, being able to frame that vaccine, that herd immunity against these diseases as an asset that is at risk could be persuasive. And that's easier to do when the risk of that herd immunity is more salient.
So that's really, there's something almost counterintuitive about this. As the risk goes up, as the threat increases, we more all can appreciate and see the value.
Yeah, I don't think that's worth the cost, but I mean, that's a very high price to pay for a little bit more attention and recognition of the benefits of these vaccines. But it is a potential silver lining if things go the way RFK Jr. seems to want them to go.
It makes me think of this. We interviewed an epidemiologist who was at the ground zero in Lubbock, Texas, of the measles outbreak this year. And we were asking her about, moments of hope as she's combating all the things that she's combating. And she talked about how a mother of 5 or a mother of 4, but a mother of multiple children who never had her children vaccinated came in and got her kids vaccinated. That's exactly what you're talking about.
Yeah. Suddenly, these diseases sort of come home to roost, and that feels scary.
Okay, Paul, many people in the audience want to know how this potential change, will affect the availability of future vaccines. You were alluding to this a couple seconds ago. In particular, the next round of annual COVID and flu shots. The administration has not been clear about which vaccines this policy will apply to, as we've discussed. But if annual COVID and flu shots had to be tested under this new policy, what would that look like? How long would that take? How much might it cost? What are the stakes here?
So I
To
don't
the
think
best of your, because we know we don't have answers, but
I don't think this is going to affect flu vaccine. I mean, the flu strains were picked in March because they had to have been, because it's for the vaccines that are made in eggs, it's a 6-month production cycle. You need that vaccine before winter. So I think the companies are going to move forward and those vaccines are going to have them by no later than September, and we'll be able to vaccinate. They're fooling around with the COVID vaccine. So they're saying things and it's unclear what they mean. I'm an optimist, I'm a Philadelphia Eagles season ticket holder, but I am the belief that they will pick 8 COVID strains on May 22nd. It'll probably go along with what the World Health Organization has done, which is JN1 or KP2, likely. And then it's a 3-month production cycle for the mRNA vaccines, and they will then be available 3 or 4 months from now. The notion that you would have to do a placebo-controlled trial doesn't make any sense. I mean, how big is it going to be? How long would it take? I don't think they're going to mess around with that. I don't. So I think
thank you. But just to indulge the curiosity of the audience, what would that look like?
I don't know what the trial they're asking for. Is it a large safety trial? Are they trying to find a problem that is occurring in 1 in 50,000 people or 1 in 100,000 people? That's not going to happen, but it will happen in the post-marketing surveillance systems that are in place, like the vaccine adverse events reporting system or the vaccine safety data link. That's where you pick it up. That's why you do it that way.
Just so people can have, you've got a whole context for this, Paul. Most of us don't. So let's just say, for example, it was a large safety trial. What would that involve?
First of all, you can't give placebo knowing that this virus, SARS-CoV-2 virus, is circulating. You can't do that. So I don't see any institutional review board ever signing off on the ethics of that kind of trial.
Fair enough. Let's talk about the ethics of that for a second. Our producer Ryan Levy came up with this. He put me in touch with a post from your Substack, Beyond the Noise. You wrote this on July 1st, 2023, and you talked about, in 1954, Jonas Salk's polio vaccine. And you mentioned that, I really appreciated this. You say, after when the trial was over, the vaccine was declared safe, effective, and potent. Church bells rang out. Synagogues held special prayer meetings. Department store patrons stopped to listen to the results of the trial over loudspeakers. How did we know that Jonas Salk's polio vaccine was effective? We knew because 16 children died from polio in that study, all in the placebo group. We knew because 34 of the 36 children paralyzed by polio in that study were in the placebo group. These are the gentle heroes we leave behind. You ended by saying, I suspect that none of the parents who volunteered for Salk's polio vaccine trial were hoping their children were in the placebo group. Why did you write that, Paul? And how does it apply to what you're saying right now about the COVID placebo trial, if we were to do that?
Well, there's a certain casual cruelty to placebo-controlled trials. I mean, if you look at even the COVID trials, I mean, there were hundreds of people dying a day when those trials were being done. I can promise you that the people who volunteered for that trial were hoping they were in the vaccine group. And in fact, a friend of mine in North Carolina called me. He volunteered for the trial, didn't know what he was going to get, because you don't know which one you've gotten. And a couple of days after he'd gotten the shot, whatever it was, he had sort of low-grade fever and headache. He was starting to have some lymphadenopathy under his arm, and he looked at his wife and said, "Yes, I got the vaccine." So I think that's sort of the way this plays out.
And so, Alison, what is it that, as we sort of contemplate what it would mean to do placebo trials where we already have vaccine. Can you just sort of, I'm not blowing smoke. You always do such a great job of this, of synthesizing points and ideas. Depending on the definition of new, depending on what this policy actually is, what potentially is at risk if we're talking about placebos, doing these placebo trials for vaccines where we already have vaccine?
In terms of the public's trust and perceptions?
In terms of people's health and safety.
I mean, that I will defer to Paul on that. But I just want to remind everyone that not everybody is a Paul Offit in terms of their understanding of this process. And the reason these policies are so dangerous is the vast, most of the public, like, it doesn't get this, doesn't need to. Like, we don't know how our cars work. We don't need to know how vaccines work and how vaccine trials work. But when there's these sort of loud, again, clickbaity pronouncements coming from the federal government, it's really easy to pay attention to that. It's sort of a simple solution to a problem that doesn't exist. And it's a lot easier just to sort of take that information in and be like, okay, I know what I'm doing, compared to sort of the difficulty and the nuance of understanding placebo-controlled trials and the ethics of them and what an mRNA vaccine does. So I really worry about the danger of this policy. I don't so much know the vaccine trial processes as much as I know what's going to happen inside people's heads as these policies roll out.
Final question on this, one more pass at this, Paul. I want to really try to understand here. If the administration were to really try to do these placebo tests and be confronted with these ethical challenges, what could the administration do this? Could they give placebo to somebody, even though, COVID's out there? Could they give placebo to somebody? Is that possible? Could they get around what other ethics challenges there are?
I don't see how. It would also clearly delay the vaccine. I mean, although one would have expected that SARS-CoV-2 would sort of settle into a flu-like pattern, which is to say a winter respiratory disease, like the other 4 strains of human coronavirus that circulate every year in this country. It's still, for the most part, year-round, but it's still a little worse in the winter. So you really would prefer to have the vaccine before the winter happens. I can only imagine that if they add this extra burden, that would delay the vaccine. But again, I just want to emphasize, I can't see how one could do this trial. And they need to define what they're looking for. Are they looking for efficacy? Are they looking for safety? It's going to be hard to do that in this current climate where there's a high level of population immunity.
And just this is just a very rule-based question, Paul, but it's the federal government. Can the federal government do what? Are there rules? Are there laws that prohibit them from doing this? Can you please tell us what those are?
Yeah, well, they're done generally, in centers that require institutional review board approval. So it would be hard to do that, I think. But Alison may have more to say on that.
Yeah.
Just like Belmont Report. I mean, we have some like bedrock ethical approaches to research that this would violate.
Several folks, including Mike Wexler, asked what impact this will have on the Advisory Committee on Immunization Practices, also known as ACIP. This is the committee of non-government experts that closely studies vaccine data and makes recommendations to the CDC about which vaccines people should get. Obviously, with so few details, I know it's hard to know anything definitive, but as someone, Paul, who has served on this committee, how could you imagine their work being impacted?
I think it's already been impacted. I think that when you have the HHS and the Secretary of HHS say things like, I think that we are going to not recommend this vaccine for pregnant women. I think we are not going to recommend this vaccine as a yearly vaccine for children. That's the ACIP's decision. And so for all of RFK Jr.'s talk about radical transparency, he's just made a decision by himself or in collaboration with, say, Marty McCary, behind a closed door without ever vetting it through a body that has expertise and experience. The American public doesn't benefit from that.
Alison, anything you want to say about this?
No.
So what about truly new vaccines? For example, might mispronounce your name here, Shabnam Sadakat, sorry, asked about avian flu and whether this could impact our ability to combat a potential outbreak of that. What impact do you expect this to have on the development of new vaccines?
I'll start and then turn it over to Alison. I think here's what worries me. You have really seen a fraying of the CDC's ability to do surveillance. And I think at the FDA, that sort of the veterinary group that was associated with, again, looking at avian flu, have also been eliminated for the most part. So you're cutting down the infrastructure that allows you to do one, the most important thing, which is to see whether or not this influenza strain, the so-called H5 strain, whether it's H5N1 or whichever N it was associated with, whether it has mutated, changed to the point that it can now bind to cells in the upper respiratory tract, so that it can reproduce in the upper respiratory tract, so that it can be spread or transmitted from one person to the next. When that happens, you have an entire population, for the most part, that is susceptible to this virus. And it's never happened. I mean, the only pandemics we've ever had have been with H1, H2, H3 viruses. I should take a step back. Influenza is a bird virus. And there's sort of 16 different types of hemagglutinins, which are this sort of protein on the surface of the virus that allows the virus to attach to cells. The only pandemics we've ever seen in history, in human history, are H1, H2, H3. We've never had H5, H7, H9, never. And we may never have that. But it might happen. And if it does happen, we need to be ready. And I feel like the surveillance system is down. I feel like the vaccine infrastructure is fraying. And I do worry that we would be able to respond quickly, especially giving a Secretary of Health and Human Services who clearly is anti-vaccine. And I do worry about that. I think we should worry about that. And also, in addition, one other thing. So there are 24 countries that have experienced H5 virus. There's probably been about 900 or so deaths from H5 viruses. Our international collaboration is important, and we've done everything to back away from or distance ourselves with the elimination of USAID or PEPFAR or backing away from the World Health Organization. That is not a smart thing to do. These viruses do not recognize country borders.
Alison, how does even having this conversation impact people's confidence in new vaccines, like an avian flu vaccine? What do we know from the evidence about what happens in people's brains when they hear this kind of talk about vaccine safety?
Yeah, I mean, there's so much, there has been so much conversation since the COVID vaccines were coming out about trust and the public trust and trust in vaccines. People don't mistrust information. They mistrust people and institutions. And, there was a lot of demand during COVID from the behavioral science and social science and communication science community for, messaging that would engender trust or build trust or restore trust in the vaccines. And I guess I would say, there isn't a message or a nudge that's going to restore trust. This is really slow work because it's so tied up in people's identity, people's social networks. It's really hard and uncomfortable for people to adopt a new attitude or belief that contradicts a prior one. It just doesn't feel very good or contradicts someone they admire. What this is going to do is just make this process messier. It's going to put more barriers in the decision-making process for, say, parents contemplating the childhood schedule, because there's all this controversy, there's all this uncertainty. Vaccines aren't safe. They're clearly not, because the secretary has said we have to do all these different things. All of those, in addition to logistical barriers and access barriers, are what delay or postpone or shift people's vaccination behavior. So I just worry that, again, with the floodgates, the same floodgates that we're going to open for the state policy, I worry that the floodgates of just introducing a lot of sort of doubt, and I have to do my own research and pay attention to sources that aren't very credible. That's what this kind of policy allows for.
I really appreciate what you said at the top of your answer when you said people mistrust people and institutions, not information. I want to end. We've got just a couple minutes. We have 3 minutes left. And Alison, a question for you comes from Jennifer Smith, who asked, how can we increase confidence in vaccinations. If we're going to be serious, you have some data, you have some evidence. There's no easy answer here. I know that. But if we're serious about engendering more public trust in vaccines, what should we be doing?
I mean, I'll give two opportunities that I see. Again, neither of these is easy. They're upstream things. One is, maybe we could put it under the umbrella of scientific literacy or information hygiene. It is like teaching the public, especially kids, how to spot misinformation. It is not hard to look through RFK Jr. statements and see where it's coming out of the misinformation playbook. We should have more kids and teens and adults who can recognize that and be like, huh, why is he trying to fool me? So that's one. And the second, this is even harder. I think we have to equip providers who are, at least for the parents making the decisions around the childhood schedule. Most of those conversations are happening with providers, and we need to equip them with the ability to have sort of short but effective conversations that recognize where the parent is coming from. Most providers will kind of have their spiel about vaccination, and it turns out that different parents need different spiels, and different spiels take different amounts of time. And those kind of evidence-based provider counseling strategies that help clarify, the priorities the parent has and the actions they can take, can also be effective.
And so what would that policy look like coming out from HHS, particularly on the second point, not spotting the disinformation, but equipping providers with better ways to engage and talk with the vaccine skepticism and hesitation that is out there, particularly among parents?
Well, I mean, there was until very recently a pretty robust NIH funding portfolio for research on this. I've been funded, many of my colleagues have been funded to learn about this decision process and develop and test interventions. A lot of those grants have been cut since January. I don't think there's going to be a robust future for vaccine confidence research. But that's where it comes from. It comes from developing evidence-based strategies and then implementing them through professional networks or health systems or payers, so that providers feel equipped to start and have those conversations.
That feels like a full circle moment, and we have more or less reached our time. I wish we were all in a room together, because I know the applause would be pretty damn loud for Alison and Paul. To both of you, thank you so very, very much. Paul, you did a great job speaking slow. Loved it, buddy. And I just want to direct folks to LDI's work, Tradeoffs work. If you're interested in learning more about the policy changes and proposals coming out of Washington, you can go to LDI's website. You can also check out our coverage at tradeoffs.org. And I just want to thank everybody else and turn this back over to you, Rachel. Thank you.
Great, thank you. Thank you, Alison and Paul, for that great conversation, and Dan for moderating it so ably. As you can see, we are continuing the Decoding the Moment series, and our next seminar is 3 weeks away. We'll be on cuts to violence prevention programs, and that will be on June 6th. You can register for that event on LDI's website. And again, we will ask you what you most want to understand about the Trump administration's proposals in this area. Finally, please keep an eye out for a post-event survey. We will be emailing it to all of you with a link to the recording of this seminar. We want from you about your thoughts on this discussion. Thank you, everyone, and have a great day.